later.
Yeah.
So hello everyone who's listening. My name's Seamus Botmakin. I practice clinically at the Durham VA Medical Center. I've worked in a variety of different settings, the psych ED, as a psychiatrist co-located in a primary care clinic, general outpatient psychiatrist, and individual and group psychotherapist. I'm also a clinician educator in the Department of Psychiatry, where I'm an associate program director in the psychiatry residency. And I think most relevant for our conversation today, where I've taught advanced clinical interviewing to psychiatry residents through an experiential class for about 10 years. And like many of you, over the past 2 months, I've shifted my work from face-to-face encounters to video or telephone visits entirely. I know, or I believe from the conversation that I had about a week ago that the work that you all are doing is a mixture. But I'm only doing telehealth, broadly construed. The conversation today will be focused most directly on video visits, and what I have to share with you all, I have about 25-30 minutes of material that I'll talk at you about. Although if there are any questions, I've got the chat open. And then I was hoping to have a conversation about what I lay out. And where it comes from is it comes from trainings that I've received and additional stuff that I've been learning from colleagues of mine who have been doing online psychotherapy for about 2 decades at this point and have been writing and researching in the area. So Amy Kawasaki reached out to the Vice Chair of Education in Psychiatry to ask if there was any guidance, or maybe she was just talking with Jane, I can't recall, and Jane thought to ask me, and so that's how we ended up here today. Where I wanted to start is a metaphor for the challenge that we have in front of us that I heard about on the radio a couple of days ago, and this is campaigning in the presidential campaign. So I didn't know the term for it, but all the glad handing and handshaking, apparently it's called a rope line in campaigns. And Joe Biden's campaign has tried to figure out what to do to be responsible in this setting, and is doing something like this, which has turned out to be not at all the same for a lot of the reasons that I'll talk to you about. So when he's in the center of the crowd and moving through the crowd, there are a lot of social cues that communicate to people who are reaching out to just shake his hand that the time to have an in-depth conversation is not in that moment, that it's unlikely that you'd be able to speak for him for more than 10-15 seconds. Whereas in the Zoom call that he's on the right, all those same cues are not present. And in this report I heard, this is public radio, it's taking forever to do this, and you're not even doing the same kind of thing because you're not physically touching the people. I think this is just a nice metaphor for what many clinicians, especially who work in high volume, high efficiency kinds of work, who might, I heard last week, be able to room a patient, find if that one's a talker, like actually dip out of that room, go see another couple of patients, then come back and see the first patient. Those kinds of strategies are much like the rope line, are no longer available to us. Some perspective on the challenge before we just to frame things, and some reading I've done. In 2008, the EMR was actually present in about 10% of clinical settings, and over 5-6 years, it ramped up to 70% of clinical settings. And we've seen all the tumult associated with that. In our situation right now, it was only just a couple of months ago that few clinicians, I don't know what proportion actually, I don't know, Tony, if you know what proportion of the department was actually doing any kind of video visits. if it's anything like psychiatry, is a fraction of.
It was minimal, very minimal, like 4 or 5 people.
Right, and now all of a sudden, almost everybody is called upon to do it. And we thought if we thought the introduction of the EMR was rapid, this is even more rapid. So my goals today are to lay out a general theme for the work of relating interpersonally with our patients through the video visits, and that is finding ways to make implicit communication more explicit. So much like with Joe Biden on the rope line, and I'll take you through some examples. There are 4 principles that a colleague of mine has come to from his work in psychotherapy that are relevant to online clinical work that I want to let people know about, because I think you probably will be encountering them yourself. And then I have some suggestions about some clinical interviewing strategies that you might not have needed to use in the way that you were working before, but may be helpful for you moving forward. All right, so making implicit communication explicit. So just as an example, extending what we saw with the rope line, when you're meeting with patients, this is just a rhetorical question, I'm not going to get an answer. When you're meeting with patients in the clinic, there's all kinds of information that communicates to the patients that there are limits on the amount of time available for the patients to speak with physicians. So there's a check-in, there's a waiting room, there's some sort of vitals nursing, there's someone else comes out and does this. And so there's all this contextual information that allows people to note that if they're paying attention, that they don't have an unlimited amount of time to speak with a physician. Most of the time, that's good enough, and most physicians are loath to say something like, "I have 20 minutes to speak with you," or "I have 15 minutes to speak with you." We may need to in these new settings. I can, just because that information is not as available to patients. They are not getting the context cues that there's no way to communicate that there's a line behind you on the screen without giving away other patients' information. So our task is to make implicit communication more explicit. And it's really, it can feel weird at times. It can feel like when you're doing this, it can feel like you're saying things that are obvious to everyone, but that often isn't the case. So I'll give you some examples. The 2 books that I use to get a lot of what we're talking about, that I can recommend them both highly. Probably not the therapy one for you all, but The Digital Doctor is gave me a lot of useful information. So some general principles about the video visits that you may have encountered already. So as a clinician, no matter what we try to do ahead of time, we have less control over the setting than we do when people are coming to see us in the office. This was made most apparent to me a few weeks ago when a weekly psychotherapy patient that I see showed up on the Zoom without a shirt, covered in a blanket, and on his couch. And I hadn't thought to give him guidance to dress as if you were appearing for a clinic visit. At the same and with other patients, there are other people sometimes in the space. No matter how much guidance that I've been giving, you just have less control over the setting. So this is something that you're noticing, I'm sure, but something to remember and probably practice a combination of both trying to develop some change-oriented strategies, some problem solving, and also some acceptance. I got caught in my own head. I also facilitate a DBT skills group, and DBT is a kind of therapy for patients who are chronically suicidal and emotionally dysregulated. So it was a challenge when we were meeting face to face, and now to do it online. Quite anxious, trying to think through all the different options. But really, a lot of this you can't necessarily know ahead of time until you're in the situation, and then you have to do some improvisation. That's what. So it's just objectively true that you have less control over the setting than you did when you were meeting with people face to face, no matter what. You may be tempted to ignore the background. My background right now is the Durham VA Medical Center. It's I don't mean that background. I don't mean the virtual background. I mean things that are happening on your screen that the person might not think that you're seeing, or you might be tempted to be polite. So, for instance, you might notice someone walk behind your patient after you've already had the conversation about, having a, or at least I have to have the conversations where I talk about having a private space to communicate. And so then someone, and it happens so quickly, you might be just ignore it. I think we do that at our peril, but just be warned that you probably will be tempted to do that. The third principle is that the virtual experience can be virtual visits can be experienced as disembodied, which is just a strange experience, and it really, you can be so focused on your eyes, and I find I have to rub my eyes and look out the window and look away and do all kinds of other things, that you can lose contact with your body, and that can cause you to lose contact with how you're feeling and what's happening as you're working with patients, and then it becomes hard to relate effectively with people. The fourth principle to be aware of is that your presence as a doctor, I wrote clinician here, but doctor, is less apparent to your patients. And I remember as a trainee seeing one of the old neurologists in the Durham VA when I was rotating in the clinic, when they would encounter clinical situations in which there weren't really many good treatment options, had amazing skill at providing reassurance. If it was a clinical situation where it was kind of an annoying problem that was probably going to persist and we really couldn't do much about it, but it wasn't life-threatening, a reassurance is a really undervalued aspect of the clinical experience for patients. So that's an example of how your presence, even just your physical body being there and giving someone your attention and focusing on them, that kind of non-specific part of people who are seeking out care for medical problems, that part of it can feel missing, both for the patient and also for the doctor. So that's something to be aware of too. All right. Let's see. So I try to do principles because really there's too many variables in clinical interviewing to anticipate every possible thing. Like, people will show up, we'll give them guidance, then at least my patients will kind of do whatever they want to do. But most of the best practice guidelines that I've seen, and in a document that was put out in collaboration between the American Psychiatric Association and the American Telemedicine Association, talked about the work that we're trying to do actually requires that the patient take a more active and cooperative role in the treatment process than would be the case for in-person locales. That was reassuring to me as I think about all those principles, all the ways in which my usual way of working is not, I have to learn new ways of working. Actually, our patients have to learn new ways of communicating and working with us as well. and we can help them do that with some of the strategies that I have. All right, so the first thing that I'd recommend to try to address some of this is to take 1 to 2 minutes at the beginning to set the agenda for the meeting. I can't overstate the value of this in my own development as a physician. I had been taught in medical school to start with an open-ended question and then start to winnow down from there. I think you can do some of that, but actually what's most crucial is to for the first 1 to 2 minutes actually say to the person, in order for us to make the best use of your time and to get to the problems that you want to work on, let's figure out right at the beginning what it is that we're going to talk about with the remaining amount of time. I also would routinely give the amount of time that I have available, and I consider that a kind thing to do. I think it's an unkind thing to do to the patient and to myself to have this idea that I'm available in an unlimited fashion, because that's actually not accurate. People most of the time really want to know how much we're available for, and then we can get down to work. I would recommend...
Yeah, this is fine.
That works?
Yeah.
Okay, so I would literally say when trying to practice this skill of setting an agenda at the beginning of the meeting, I would literally say, let's take 1 to 2 minutes to set an agenda for what we will discuss over the next 20 to 25 minutes, if that's the amount of time that you have. And I would always undersell the amount of time that I would give anybody. This is I actually get 30-minute visits for follow-ups. I like my job. So I would always say 20 to 25 if I actually have 30 minutes for the encounter. Most patients if they haven't encountered this before, they're not going to do that. They will actually just start talking about the first thing that they want to talk about. So then you actually have to say again something like that. Either repeat, let's take 1 to 2 minutes, and interrupt the person. You have to be really active. You might say at the end of our meeting, what do you want to have done? Like after you and I are finished meeting, what do you want to have done? And if that's not working, or you might start right with this, you could ask some fixed choices questions at the process level. So ask the person, so when we're meeting today, are you looking for us to assess a new problem or assess a change in established problem? So then that at least gets your mind going in one of these other directions, and the person knows, like, oh, okay, I'm here because there's something new, or I'm here because the thing that we were already working on is changed, or I still need help with it. It's not we haven't figured it out completely. I would then, so you're going to have to interrupt more than usual when you do this, and I would then repeat back the agenda to the person, and you do all this in like 2 minutes. So that you're wrapping all that up, and then you're both on the same page. You both know about what the next 10, 15, 20 minutes is about. It took some practice for me to do this, and the best way that I found to do this, and this is part of my recommendations as well, is to practice doing this with a colleague. Because it doesn't, if you're not in the habit of doing this, it's going to feel artificial and awkward at first. Let's see. So the other strategy or skill that I'd recommend is learning to be more effective with your interruptions. In the class that I teach, psychiatry residents, I actually play 3 difficult to interrupt patients. One who's manic, one who's psychotic, one who has a personality disorder. And for whatever reason, I'm quite skilled at portraying these folks. And it's very challenging to interrupt me when I'm on a roll. And so they learn something about what it is like to interrupt by practicing. Again, I recommend practicing. But try to remember, actually, as you're interrupting, what the primary purpose is of interrupting. And that is to facilitate understanding the patient's problems so that you can make a useful assessment. That's the reason you're interrupting. And if you recall that, that is often for me reassuring, and it feels less rude or abrupt, but just that's the reason you're doing it. You may need to interrupt in order to get your work done, and actually sometimes for some patients talking more and using more time talking is actually not helpful for them. Some strategies that I've found useful in general are you can make a process comment while you interrupt. So you can say something about like, I think I'm going to interrupt here, and actually describe what it is that you're doing as you're doing it. You could make, while you're doing that, you can make some sort of comment about the online experience that you might share. Like, these video visits, we're doing our best, but I got to interrupt you. I couldn't tell if you were about to speak there. You can use humor. You may have to use repetition. Sadly, the take-home message from the class that I've taught for the psychiatry residents is that nonverbals are vital to assist in interruption, and that's where we're in. It's so difficult. So like you can you can clear your throat. You can kind of display your face in a way that suggests that you're ready to talk. Catch the eye contact of the patient. None of that, I think, is going to work here on the video visits. Like all those more subtle cues are just not, they're not going to, so I think that's why I changed the slide a little bit. I think in the online environment, gestures need to be more obvious and bigger. So like you might even like some of this, like just, hey, like lean in, or like this, or like time out. With one patient in my clinical practice, I had to actually do this. I had to like show my watch and point at it. I wouldn't recommend that. I think that's a bit rude. But the big gestures are it may not be your usual style, but I think they're vital now, because otherwise you're going to sit there uncomfortable thinking that you're communicating on your face that it's time for the person to stop talking. They're not going to get it, and then you're going to chew up all that time. So with the task of making the implicit communication more explicit, I put together just something that I would say, if I were in your shoes, at the start, to kind of set the stage and to inoculate the person from being irritated with the way I'm being. I'd say, hi, I'm Dr. Bob Mackin. We're meeting for a video visit because of the pandemic. It was not by choice that most of us are in this situation. The patients didn't choose to do this, most of them, right? And most of us didn't choose to do this. In order for me to more effectively give you the best clinical advice possible, I will be working in a different way online than I usually do in the clinic. Specifically, I'll be structuring more of the interview, including letting you know how much time is available in total and giving you a heads up on how much time that we have left. I'd hit like time markers when there's like 10 minutes left. Like, hey, we got about 10 minutes left. I will be helping us form an agenda at the beginning of the meeting to make sure we get to what you want to discuss with me. And I'll probably be interrupting you more. Just lay it all out there, and then say the reason I will be doing this is to do my best by you to make this experience useful. Something like that to orient folks to what's gonna come, because it's. I don't think it's possible to work in the same way. I haven't found it possible to work in the same way that I did face to face. All right. Okay. It was about 25 minutes. So that's what I had in terms of content. I see that there are some folks who are listening in, and I thought maybe we could use the time that remains for questions or discussion about how to try to implement some of this stuff. See if what I presented was useful or not.
Well, I have a question, and it's not so much because of my experience. It's me more monitoring the experience of our providers through the existing support mechanisms. Obviously, there's been a lot of technical problems with our platform being able to deliver on the expectations that both our providers and our patients sort of have. I think naturally, as part of being a part of a robust organization, we sort of have expectation that everything's just going to work right out of the box when we open it up, like an iPhone is just going to happen. And that hasn't really been our experience. And I think there's maybe, if there's some value in understanding what your approach might be, or some tricks or solutions you have around alleviating through or navigating through that technical piece, and assisting our providers in being able to power through the visit. What might be some of the strategies that they may use to help, to deal with the fact that they're not having the experience that they hope to have, and that the patient may not be? What are some strategies around dealing with that?
Yeah, so a couple of things come to mind from my own work, and I was thinking about this, but I don't know if it applies necessarily. So in psychotherapy, when there's a rupture in the relationship between the therapist and the client, so screw up somehow, like something doesn't perform up to standards in the way that we wanted, and you're able to effectively repair that, that actually that is an independent predictor of a good outcome. So independent of anything else that you do. So trying to repair includes acknowledging what is actually happening. So that's what I would first focus on, and acknowledging how the technology is getting in the way of, or if it is, like whatever is actually happening, actually acknowledging it and owning it is the first step. Because if you're trying to sell it like it's something that it's not, nobody's going to trust you to talk about your problems. So that's the first suggestion I have, and so like figuring out how to repair. Now I'm also thinking about this talk. I'm in a little bit of a different situation in that I am not required to think in the same way about billing as maybe another medical system is required. So I can actually hone in on what I think is most clinically relevant. I can, if in the middle of a video visit, the VA has its own platform, and if in the middle of the video visit things are not going well, I can convert that to a phone call, and I don't care. But my understanding is that is actually crucial, because the phone call is different, is captured in a different way from the video visit. So the stresses that you all are under to try to make things happen so quickly, that's not a suggestion. It's just more validation for you about the situation you're in, because like things like like in the book I mentioned, it's 6 years to get a lot of people up on EMR, and now we're expected in a matter of weeks, we're expected to have all these skills. So I would remember that patients appreciate like acknowledging what's happening and trying to make some sort of repair. But by that I mean like interpersonally, being like, yeah, I screwed up here. We're working on it. We're going to do our best to do better. Something like that. Yeah, I this might be unpopular, but I would also just give more time. Like I would. What the strategy that I used to try to learn how to do this is I actually preferentially saw follow-ups first. So patients who I had already worked with face-to-face, and I targeted those folks to try to learn how to do the technology, or how to be in this environment with them first, and so I could get facile with it. And then another suggestion I have is that in terms of practicing and learning how to do this, oh, great, thanks, I appreciate the feedback. It's great talk, and I'll put it for the record. This is great talk. This is an awesome talk. So the other thing that I've done is, because I do these group therapy sessions, and I'm part of all these team meetings, we try to use the same platform for the team meetings where I'm working with colleagues as I'm doing my clinical work with. So then I've got to do those team meetings anyways. And so then I'm actually practicing the technology and practicing how I come across and what I look like and what I'm doing in a setting that feels more friendly and less risky. So, for instance, later today, a colleague of mine who hasn't done the video on demand, which is the VA version of the video visits, she and I are going to talk about how to do it, but we're going to do it by being in a scheduled visit and have a one-to-one conversation actually in the visit. I thought that was an excellent, the ABCs, that you got a chance to see what the patient's view is, and it was maybe a couple weeks ago with the Lunch and Learn. I think that's a great idea. You can also do that even not just like in a didactic way. You can actually do that experientially and have a conversation with a colleague to get a consultation question answered try to schedule a visit. Now, I don't know if that's possible to do in the platform that you're using, but I think you learn a lot by and also you can just ask questions about like, how do I look? Like how is this? Can you tell that I'm trying to get you to stop talking and stuff like that?
I feel like the idea of practicing with a colleague is a good suggestion. I would actually suggest that a provider practice with a family member or a friend as opposed to a colleague, such that it's going to be closer to the patient experience than it would be a colleague who actually is able to anticipate in some way how you're going to guide the conversation. But if you literally get as close as possible to replicating the patient, and that's more likely to be somebody who's not a colleague, but could still deliver that same sort of idea.
Yeah, and get them to play a difficult patient too.
What are your thoughts around the idea of having the documentation of the EMR system alongside at the same time as doing the verbal, virtual face-to-face encounter with the patient? About half of our providers tend to want to do it where their documentation is right in there with them or sort of side by side, and then a lot of them also would prefer to do the documentation later. Do you have thoughts around what you think might be best practice around having the EMR right up in your face while you're trying to do the video visit versus just talking and then coming back to the EMR later?
So I have two monitors. So I actually have two screens, which influences that because I can see the face of my patients or my group, pretty large, and also have the EMR up. In my face-to-face, so this is just my own. I talked about my own experience. I don't know probably what's best practice, but my own experience, I actually talk to people face-to-face, not sitting at a computer screen. So there's nothing between us. Like I actually sit down and talk to people, and then in the last 5 minutes, I actually stand up and I summarize what we've done and tell them I'm summarizing what we've done, and I type the last part of my note. I type my assessment and plan out while the patient's actually in the room, but they know that's what they're doing, and that's also a time. So that's what I'm trying to do now. I'm not skilled at it yet, but that's my practice, is I'm going to have the EMR up, be most of my attention on the patient who I'm talking to, trying to give them most of my attention, and then take the last 5 minutes of my visit and tell them that, like, hey, now we've got the last couple of minutes. I want to summarize what we did, and actually say, hey, this is what we did, and type it out and get part of my note done. And then it gives me like a little bit more time with the person, but then I'm not trying to multitask and do both things at the same time. Right now for me, these video visits are hard because I'm trying to figure out if someone's like legit psychotic with schizophrenia. Like I met somebody yesterday I've never met before. New intakes are incredibly difficult. Like I was exhausted by the end of just talking to somebody for 45 minutes. but I'm finding that the video visits are actually much harder than the in-person encounters, but the phone calls are substantially easier in terms of like the workload. So, and it's because part of it is because I feel comfortable typing while I'm only listening. So I've actually with a couple people I'm working with, and I don't know how this would affect like calling it a visit, because we want to be able to call it a visit. But I've been thinking about some of the video visits work as like a little bit more than a phone call. So I'm not. It's too painful to look at the screen all the time. So I actually will tell people like, this is not the same as when we were meeting face to face. It's more than a phone call, but we're closer to a phone call here than we are meeting face to face in terms of like my skill and my ability to do it. And so that lets me try to attend to what is going on with the person primarily through the auditory channel. Like that's the main sense that I'm using to try to understand, because I can't see, like it doesn't work. I also end up just looking at myself a lot to make sure like I'm centered, and I know that some people prefer to not have their own face, and you can remove that and all those options, but.
I see that a couple. Dr. Friedman joined partway through.
That's all true.
Um,
Any other questions from anyone in the audience?
I think, Doc, what I'll try to do is I'll arrange a way to get some feedback through a couple of different processes after people have had a chance to look at the recorded version, and
Okay.
and we might could just, it doesn't have to be something formal like this, but we might could just do a little FAQ coming out of that maybe folks might have a chance. I know some people think of things after we've gone through a conversation.
Yeah.
And then an hour or two or a day or two later, they're like, oh, yeah, you know what? I wish I had thought of this. And so we could just do a quick little FAQ that we could keep a copy of and have it available to folks down the road.
Yeah. I think I'd be willing also to just chat with a small group too. I think that like the devil's in the details. Like I laid out like these principles and these strategies, but actually like implementing them and figuring out how to make it work with like for instance in the call that we had a week ago, there was mention about the use of anatomical diagrams, which is a common thing. I can't remember if it was Amy or someone else said that we talk about vaginas a lot. So like there's just stuff that is like more specific that would come out of I think discussion and conversation, but maybe the principles that I've laid out that I've encountered in my own work might stimulate a conversation.
Sure. I think there's a fair bit of providers are not, in our case, many of them are not. They're not working at setups and workstations that are sort of designed to support a true telehealth model, right? They're adapting their MacBook at home, or they're most all of them are doing it from a portable device, and so the ability to have multiple monitors is not a foreign thing even for those devices, but many people don't deploy those things in their normal environments, and so it becomes a much more challenging experience for them to be able to go at things from multiple directions and have multiple monitors. I mean, I have 4 monitors set up in my office, but I'm a tech guy too, and not just a clinical guy. So I mean, but they're trying to do these things on laptops, or pin stations, which have limited capabilities. And so the more we think about it, I think the more we're going to find that we have to be creative around solutions to help us with our technical piece.
Yeah, that makes sense.
We won't take up any more of your time. I appreciate
Sure. Yeah.
So I'm sure that all of us will provide some feedback documentation for you as well, and
That'd be great.
maybe we could develop a little FAQ based on the interactions that we have in the department.
Yeah. Yeah. I'm eager to, like I said, I think that there are the strategies that I teach in the advanced clinical interviewing class. I think those can be useful, the principles that I laid out, but they're all, again, like, the devil's in the details. And
Yeah. I tried to take notes and then incorporate our kind of clinical world into your suggestions as part of what I was doing while you're talking. So
Yeah.
I think that makes perfect sense.
Okay. All right. Well, good to be with you all.
Thanks, Doc.
All right. Take care.